Thank you so much. I'd like to thank Dr. Joshi, Bhupika, Sunita, everybody for this topic and keeping carbohydrates alive. And I think after this very vigorous physical activity in Zumba, it's really a pleasure to talk on carbs, and maybe after the talk you can have some carbs. So as our chairperson rightly said, that we are a carb country, and what's the role of carbs and AGIs in the current era? So we are South Asians, and we have a different phenotype. We have higher beta cell function. There is a marked deficit in the first phase of insulin secretion. We have an impaired glucose tolerance. We have type 2 diabetes onset at a younger age, and we are typically thin fat, more insulin resistant, lot of inflammation, low adiponectin, a lot of susceptibility to heart disease, and a very typical dyslipidemia of low HDL, high triglycerides, and high LDL. And therefore, there is a need when it comes to treating our people. So if you see an ADHD guideline, they won't have AGIs, but when you go to China and India, AGIs are a part of our regimen because of the higher prandial glucose curve, and therefore there is a need for an individualized or ethnic specific guidance in management of type 2 diabetes. We showed in our STAR study across India that only South India doesn't consume carbs. Actually, Western India, Central India, Northern India, Eastern India, everybody consumes carbs, including Northeast. And the highest consumption of carbohydrates worldwide is actually in Central India. So our STAR study says we have a lot of carbs. As Indians, our prandial glucose curves are higher because we eat actually more simpler carbs. And we also have a first phase of insulin lost early. So we have also a beta cell defect. So we have actually a dual jeopardy, high PPG and a beta cell impact. And when we look at our STAR study, we saw that across zones, more than 60% of our diet is carbohydrates, and it's a prandial glucose curve, which is predominantly seen above 180 in our diabetic population. So we are different from the Asian population. We showed this, and this was the data from Singapore. You can see here, if you eat a sweet milk biscuit, how a Caucasian from UK will respond and how an Asian Indian will respond. And we will actually make more glucose. Or if we eat a sweet biscuit, again we will have more glucose made, and the glucose levels will go up faster. If we have a wanted whole wheat cereal, wanted wheat cereal, cereal biscuit with milk, whatever carb we eat, compared to the British Caucasian, in this study by Dr. Henry from Singapore, showed that the Asian Indian made an increased higher glucose. So we clearly recognize this fact, and there's very good data. Lou Monier said that in Western population, below 8.5 A1C it is prandial glucose, and above 8.5 A1C it is the fasting. And that's why the traditional adage was fixing fasting first. But when it comes to the Asian patients, the contribution of prandial glucose is much higher at the early stage of diabetes. And it is an independent risk factor for macrovascular complications. And if you look at from 1999, where Coutinho showed in the meta-regression analysis that there is a relationship between 2 hours for prandial glucose and CV event. The DECODE study showed that 2 hours prandial glucose was a significantly risk factor for cardiovascular disease and doubles the mortality from the Pacific Asian Indian Ocean study or the Funjata study which was seen in IJT. The Framingham score also showed us in 2002 that the offsprings of people born with diabetes and higher postprandial glucose had a higher heart disease. From Japan, Nakamura showed that the coronary artery stenosis was much more in prandial glucose. And of course the STOP NIDM trial, which is the first CV outcome trial on Panadol with the oral agent, that showed that the absolute risk reduction was 2.5% if we reduce the prandial glucose. And then of course we have several other studies across the world predicting this. And the latest in the pecking order of prandial glucose which matters actually comes from personalized medicine now. We all are looking at CGM maps, and we clearly see these maps coming up. So if you control glucose, risk of cardiovascular factors comes down. Because lower the prandial glucose, lower is the lipid profile, lower is the blood pressure, lower is the hypercoagulability, lower is the inflammation and slower progression of atherosclerosis, mainly the carotid IMT can be partially reversed. And therefore, when we have a treatment approach in our population like India or Asia, we need to stop progression of diabetes. We need to target prandial glucose. We need to protect early loss of beta cell function. We need cardiovascular benefits which promote weight loss or weight neutral, and we need a safe and tolerable profile. And therefore, alpha glucosidase inhibitors which delay glucose and carbohydrate absorption, reduce prandial glucose, is been a standard of care. And in India, we are now more than 25 years experience with acarbose, lot of scientific evidence, more than 600 plus clinical trials in diabetes patients from China and Asia and India, more than 2,000 publications, more than 70,000 patients worldwide, and more than 45,000 patients of the Indian origin. And what is acarbose? Acarbose is the first of its kind. It mainly delays intestinal carbohydrate, it lowers prandial glucose, it leads to a lesser need or beta cell stress on the beta cells, it improves insulin sensitivity, and it actually facilitates the GLP-1 release and actually causes gut microbiome changes. So it is a built-in gliptin, it is a built-in microbial modulator, it is definitely having a lesser stress on the beta cells. The beta cell stress test is positive, less, and acarbose has been the first agent of its kind, and it was a German product but most commonly used in China and India. And clearly we see that with acarbose there is an insulin sparing mechanism. The insulin requirement is lower, prandial glucose is lower, and in the Asian Indian diabetic patients you can see data which is published clearly showing that the 2-hour area under the curve is lower. And recently IDF came out with a 1-hour guideline where Dr. Peter Schwartz and Dr. Mohan and many others were involved, and they clearly showed that 1 hour also matters, just like 2 hours, and acarbose also has an impact on 1 hour in this slide as you see it. Also, when we look at body weight and hypoglycemia, actually this is an agent which can be used in reactive hypoglycemia. I use a lot of acarbose when people get reactive hypoglycemia. A lot of pre-diabetic patients get into a low glucose level, and it's an agent of choice. After bariatric hypoglycemia, it's an agent of choice. And many people living with type 1 diabetes use acarbose because they often want to eat fast-acting carbs and they don't want a very peak and valley effect, so I use it very commonly. Even in GDM, it is a category B indication. So acarbose is one agent which can be used universally because hardly gets absorbed in the body and has reduction of body weight because it's a starch drug. This is some data which we showed long time back that acarbose is different from say a voglicose or a miglitol. Because what it does is when you see here, when we eat food without acarbose, there is a exposure of K cells in the upper intestine and the lower intestine. And that is the K and the L cells make the GIP and the GLP-1. When we give acarbose, because of the delayed carbohydrate absorption, you can see there is a better impact on the K cells and the L cells, and therefore there is a better production of GLP-1. This is published data that 60 minutes after acarbose, the GLP-1 production is stimulated, and because that is mainly because of the unabsorbed carbohydrate, because the carbohydrate has a longer shelf life in the gut. And when we actually add on a gliptin to acarbose, the prandial glucose comes down further and the area under the curve comes down further, and the GLP-1 goes up almost into pharmaceutical levels. So clearly we have large data, and the Cochrane analysis showed that the A1C drops down by up to 1% with acarbose. Meta-analysis showed that the Eastern and the Asian population, the A1C reduction can go up to as high as 1.5. So in the Caucasian population they eat less carbs, so their efficacy is lower. More carb you eat, more sweets you eat, more carbohydrate foods you have, more dosas and appams you have, the better is the drop in A1C. That is something which is very, very well documented. And there is data from India. For example, this is the GlucoVIP multinational, real world evidence study, which is nothing but the GlucoVIP view of patient groups. And clearly you can see in the Indian subset, the prandial glucose curve was much more pronounced, and the A1C drop was 1%, and 80% of them were receiving acarbose less than 150 milligram per day. And when we combine it with metformin, there is synergy and there is preservation of beta cells. So it's a very, very high impact agent which preserves beta cells, lowers prandial glucose, and is very, very robust. Very high impact journal, Annals of Internal Medicine, 4 years back published the comparative effects of glucose lowering drugs. And alpha glucosidase inhibitors are pretty robust in their A1C lowering therapy in drug naive patients as well as in the metformin induced patients. So clearly, the first, as I told you, IGT study with CV outcome was the stop NITDM study. It was headquartered in Australia, mainly done in China, and you can see that this was very clearly showing that in a large group of pre-diabetic patients, it actually prevented diabetes. In fact, acarbose was the first agent before metformin approved by Indian Drug Control as an IGT agent. And it caused reversal of normal glucose tolerance. So in India, if you ask me 20 years back, acarbose was approved as a remission agent, agent which causes diabetes remission. And this was a GLOBE study, again published by Dr. Sabu, and it clearly showed in the GLOBE trial, which was a phase 4 trial of 8,000 plus Indian patients, the prandial glucose comes down by 80 to 100, and the A1C in the GLOBE study showed it came down to by 2.8%. So it's a very, very strong agent compared to the popular perception. So when we come to the Indian guidelines, and Dr. Makkad is here, he led when he was the president of RSSDI, the Indian RSSDI guidelines, and the ESI guidelines was also there, and Dr. Madhu was there. And that was clearly recommending that in the ABCD, EF, GH, for Indian type 2 diabetic patients, alpha glucosidase are a standard of care. IDF also says that if metformin is not well tolerated, the alternative is an AGI, gliptin or a SU, and it's a perfect add-on. In Japan, it's right up the pecking order, and in China, it's a first line agent. In fact, they use acarbose before metformin. They feel it's a very, very high impact agent, and the largest prescribed drug in any category, independent of the medical specialty in China, is acarbose, and in diabetes, the largest prescribed drug in China is acarbose, because they believe that carbohydrates matter, and in India also we should be mindful of it. So clearly, what we recognize now is acarbose is having benefits beyond glucose control. It has very good CV benefits. It reduces body weight, and it also impacts gut microbiome. So we know that with the CGM, we can study the prandial glucose variability. And we know 50% of glucose variability of the peaks and valleys because of prandial glucose. And the excursions are more prominent in Indians. And therefore, the RSSDI recommends that acarbose contributes significantly to reduction of this GB or glycemic variability reduction, and decreases of blunts of prandial glucose spikes. This was another study published in 2020 with a randomized control study of metformin, acarbose in treatment combined with pre-mixed insulin. And even when we combine with pre-mixed insulin, you can see the mean amplitude of glycemic excursion is reduced with acarbose. You can see the clear-cut data of the coefficient of variation, MAGE, and standard deviation, and you can see lower glycemic variability. And therefore, addition of acarbose to metformin, even with a gliptin, reduces the intraday variability. So we are able to get more patients under larger area under the curve, and it also impacts the cardiovascular risk factors. So if you add it, you can see not only the glucose, the body weight, the BMI, the triglycerides, the lipids, the inflammatory markers like CRP, all of them are reduced. And clearly we can see that indirectly from this Beijing community diabetes study, which looked at acarbose therapy with CV events during 10 years follow-up, the acarbose had lower incidence of myocardial infarction with a statistically significant value of 1.7 versus 3.75, and all-cause death which is also statistically significant. So clearly you can see that 446 endpoints occurred less with the MACE of all-cause deaths, CV events and cerebrovascular events. Even the real-world data supports that when there is a 33% relative risk reduction for stroke, 31% relative risk reduction for atherosclerotic events, and 34% reduction from hospitalization for myocardial infarction. This study was published in the Journal of Clinical Endocrinology and Metabolism. Again, you can see here, acarbose reduces body weight irrespective of glucose control. So it blunts the body weight. It has a positive impact because it's a starch blocker. And it also has an impact on gut microbiome. In fact, we wrote this paper way back in 2015, almost 9 years back, where we can see that the acarbose facilitates production of short chain fatty acids and hydrogen gas by fermentation of the undigested polysaccharide. And therefore what happens compared to a vocalipose or a biglitol, there is higher polysaccharide available in the large intestine. And therefore what acarbose pushes the polysaccharide to the colon, it increases the colonic bacterial mass. And then that facilitates production of short chain fatty acids and hydrogen gas by fermentation of these polysaccharides. Because more polysaccharides in the colon, more will be the hydrogen gas, more will be the short chain fatty acids. And both of them at the tissue level, you know, are antioxidant. And this is again data which shows acarbose has a very good effect on the entire gut ecosystem compared to say avildaglutamine. And the microbial changes are induced as early as 3 months and they are long lasting. So very good data by Professor Linongji, who is a good friend of ours, in a metagenomic analysis reveals that there is a crosstalk between the gut microbiome and the Chinese people living with type 2 diabetes. And this is a randomized double-blind placebo-controlled study in which you can see that after acarbose, the 5 genera of gut symbiote, which are good microbes in the gut, are all increased by acarbose, and the bad microbiota are lowered in the 6 genera, whether it's Butyrosis or Bacillobacterium ruminiscens, and out of the 108 genera identified, 40% of them have a higher abundance with acarbose. So you can see that it really makes your gut more healthy. And the new data which has come up now in 2024 is acarbose now ameliorates even the memory. This is data on a mouse model in Alzheimer's disease. And what they did is they took mouse and they were having glucose intolerance. They put them through a metabolic chamber, a behavioral assay, collected their tissues and gave them acarbose. And clearly you can see that in the transgenic mice, clear data to show that actually acarbose decreases body weight and adiposity. In those mice, increases energy expenditure, stimulates the glucose control, and the worsened cognitive deficit is repaired. So actually acarbose may be promising intervention to prevent, delay or intervene even in Alzheimer's disease. And you know, type 3 diabetes is nothing but Alzheimer's disease, who consume a lot of Western diet or a carbohydrate diet. So fundamentally, I think I wanted to highlight these key messages. That we did the STAR study which showed that we are a carbohydrate country. Whether it's not just for South India, I'm in Kerala, I'm mindful of that, but across India we eat carbohydrates, including northeast of India. And compared to the Western diets, we have simple and complex carbs both, and we are fibrogenic. Just like we have less muscle mass, we also have less fiber. Second is when we have a higher prandial glucose. You know, it is still relevant. IDF has gone back a guideline just this year stating that 1 hour, 2 hour glucose is very important. Westerners are only doing fasting in A1C. They are not measuring the 1 hour and 2 hours, and we need to recognize that. And acarbose has been approved for IGT, type 2 diabetes, even for type 1 diabetes. It has been approved in India as an adjuvant. It lowers the post-meal insulin requirement, improves beta cell function, lowers hypoglycemia, lowers weight gain. In fact, it's weight neutral, it can cause weight loss. It's very good for our population, our diets, controls the prandial peaks, reduces cardiovascular risk factors, and it's the only, acarbose is the only AGI which allows polysaccharides to enter the gut promote gut symbiosis, enhance GLP-1 secretion, and animal data shows it might have a mental health effect also. Thank you so much for a patient hearing.
Thank Dr. Shashank R Joshi sir for highlighting the impact of carbohydrates on HbA1c and the role of AGIs in tackling the postprandial glycemic excursions. So very frequently in our clinical practice we see patients with uncontrolled HbA1c just because these patients are having high postprandial glycemic excursions. We would be happy to take few questions.
Yes. Sorry?
What's the Carbs versus Voglibos? The merits.
So I told you that Voglibos is a weaker agent. The data is not published. All the data Voglibos uses is Carbs data. It causes less flatulence. Voglibos causes less flatulence, but has no cardiovascular effect. It does not cause any impact on gut microbiota because the Voglibos is a smaller and a weaker agent. So Voglibos is a agent which is not as potent as Carbs. Carbs is only challenges the flatulence as an adverse event, and which is actually an advantage because it is fermented as hydrogen gas, which actually has a CV beneficial effect. So Voglibos is nothing but a starch blocker without the evidence-based advantages of Carbs, without the cardiovascular advantages of Carbs, and therefore it is not actually standard of care. But in India, India is the only country which uses actually Voglibos, though it is discovered in Japan, and only 3 countries have approved of Voglibos, while worldwide Carbs is approved from United States to Europe to Japan to Germany, because Carbs was discovered in Germany.
I think I have 2 questions to ask. Shashank, have you used Carbs for the rapid reduction of glucose compared to other orals?
Oh, absolutely. Suppose somebody wants to go to cataract surgery in 3 days.
Exactly.
I start with Carbs and you can put the payload to give them insulin.
And their ophthalmologist will not touch without BP sugar being controlled. So
Correct.
therefore, it's a great drug to control diabetes before.
It's a fast-acting drug.
Second thing, my question to you, I know we have shared stage where you spoke absolutely fabulously about this drug. I'm very curious. Tell me, Shashank, why the drug is not maximally used? Is it because the inertia on the part of the pharma company, or what is it? I will wonder sometimes. It's a wonderful drug which has no side effects, and you always say flat is a good sign.
So it's a good question. I'll answer your question. Carbs is very difficult to make as a molecule. It is made by, like insulin, by fermentation technology or biotechnology. So it's a biotech drug, and therefore it cannot be very easily copied. So Indian companies don't see major profit in making Carbs compared to say Voglibos, because Voglibos is very easy to make and replicate by reverse chemistry, while Carbs is a biotech fermentation drug, so more difficult to make, and therefore there is a single company which makes it, but it does very well. In China also they do very well.
And why no combinations? Voglibos has myriads of combinations.
Carbs does have combination with metformin, it's available.
Available. Thank you.
Yeah. Yes, there is data on that, and that is because it improves the vascular permeability. And you know that erection is a vessel phenomenon, and therefore it is documented. There are 4 papers published of Carbs in erectile dysfunction.
Say, Carbs can be used in all trimesters of pregnancy.
Sorry?
Pregnancy.
Pregnancy is a category B indication. There are 3 drugs with category B indication for pregnancy: metformin, Carbs, and third one is actually suppressing the glibenclamide. All the 3 can be used, and usually we don't recommend oral agents to be used after 2nd trimester.
The maximum dose of Carbs in CKD patient.
So don't go beyond 150 milligrams. In CKD patients, don't go. Try to keep it the dose below 100. Total dose. Thank you. Yes, ma'am.
I have one.
So in reactive hypoglycemia, peribariatric surgery, it's a great drug. Start with 25 milligrams 3 times a day. Take it with the first morsel of food, and it does extremely well. So don't give it before food or after food. Take it with the first morsel of food. Same thing is true with pre-diabetes. Pre-diabetes is the agent of choice. Top anti-diabetes which trials showed not only prevents development of new diabetes, but also reduces the population incidence of heart attacks. reduce heart attacks.
I understand that Indian physicians have been using Acarbose for more than 10 years.
Sorry?
Indian physicians have been giving Acarbose to patients for more than 10 years now. No. Do you have what side effects have you noticed?
No, actually, once you start using the drug, the side effects are seen in the first 3 months or 6 months. Once the patient gets used to it, you don't see those side
What
effects.
are those side effects? Only flatulence, no hepatorenal side effects. No side effects like that.
No side effects. People have used it for 20 years now in India, 25 years of life.
Excuse me, sir, we are running out of time.
Now we have got one important ceremony here. Give a plaque to
Yes.
your speaker.
Yes, requesting our chairpersons, can you please step forward to hand over the citation to Dr.Shashank R Joshi. Ladies and gentlemen, let's put our hands together to Dr. Shashank R Joshi. Thank you so much, chairs and speaker, for the wonderful session. And now moving to the next session, that is future therapies for obesity management.